This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you very much, Daryl. I wanted to thank everybody for being here today. I particularly want to thank our sponsors, without whom we would not be here also. Thank you. The Society is now 2 years old, and the nice part about it is we made it 2 years, and I'm very excited about that. In fact, as of this moment, I'm no longer the president. Our new president is Gary Smith, and I think it's an important moment in any new organization to have a turnover of power, and I'm happy to turn over the power. To Gary, we have a new leadership, and we'll be discussing more of this at the general membership meeting tomorrow. I hope many of you choose to attend. It'll be at 17:20. I believe it's in this room, and it runs for 40 minutes, where you'll get a chance to meet our new board and our many members, not all the members of our executive. So this is the third meeting we've had since we've had a society, and it is really exciting to see so many people here for this meeting. When we started this trek, which is now well over 15 years ago, I think we had hoped that we would wind up here, but to actually get to where we are is very exciting. And I think, if anything, our future is even brighter. Let's see if I can go forward here. So here's our mission statement: prevention and response to acute deterioration in hospitalized patients, with our goal being zero. I was challenged with this goal many years ago. After having spent 5 years perfecting our code team, my boss at the time, who gave me the task of fixing our code team, I had told him, all right, I'm bored now. Our code team is fast, they're well equipped, they're really trained. And he said there had been a code that morning. And I said, yeah, it was a thing of beauty. It was lovely. The patient was shocked before most of the team got there. The resuscitation was rapid. What happened to the patient? Well, the patient died. And this is a quote: "DeVita, you're an idiot." He said, there should never be a cardiac arrest in hospitals. He said, we should either be making patients NFR, not for resuscitation, or we should be preventing the cardiac arrest. Either way, we shouldn't be having doctors running around trying to bring people back from the dead. That's a failure of our system one way or another. And of course, I told him how wrong he was, only until I found out that he was right. And it was in the review of charts of patients who had coded that I could see that there were opportunities to prevent. And that got us started, at least in the U.S., at the University of Pittsburgh, on their rapid response system as we now know it today. Of course, I think everybody knows that Australia was way out in front of us even then. But we joined forces quickly and have now gone on to make an organization. So hospitals, it turns out, you may already know if you're here today, are not safe places. The pinnacle of safety in healthcare is transfusion-related medicine. And there's about 1 in a million transfusions that results in death. ASA-1 surgery has a very high success rate. But if you're looking at the cardiac arrest rate or critical deterioration, preventable critical deterioration, the rates are really kind of scary. 1 in 100, 6 in 100. And it is way beyond that where we see in other high reliable organizations. And this is air accidents that occur over many decades since civil aviation travel began. And you can see that the number of even though the miles flown is going up, the number of critical incidents is going down. And this is highway safety in the United States. Blue is the miles traveled, and red is the deaths per billion miles traveled. And getting here requires a lot of work that occurs over time, and you could see the slopes are going up and down. It is expected that this slope of the red line is going to decrease rapidly over the next 10 to 15 years because of the introduction of new technologies. Auto manufacturers are working from creating airbags and safe bumper systems, which is recovery type of, so you've had an accident, let's save the lives, to automatic braking systems and even automatic driving systems. So the actual accident, they're moving upstream from the accident, and this curve is expected to take a really swift turn downwards in the next decade. So we've talked about two high reliability organizations. There are others. In addition to airlines, rental car companies, hotels, FedEx is a brilliant example of a high reliability organization. And the things that these companies have in common is the ability to recover from error without harm, and then to learn from mistakes. So near misses are as important as hits when it comes to auto accidents and airline accidents and misdelivered packages and late packages. And the credo that we had was it doesn't matter what happened. What matters is what might have happened. Try to sort that out and prevent the might happen from does happen. We need to plan redundant systems. So when everybody here has booked a hotel room, they ask you to choose the date that you're going to arrive, the time that you're going to arrive, and then they ask you to confirm it. And this is done so that they don't give you so you don't make a mistake in making the reservation. However, sometimes mistakes occur. Has that ever happened to you where you go to a hotel and you say, my name, you won't say my name is Michael DeVita, you say my name is whatever your name is, my name is Michael DeVita. And I have a reservation for today, and they say, how do you spell DeVita? And so I spell it, and they said, is there any other spelling? And I don't know about you, but even when the reservation is gone wrong, I never wind up sleeping on the street. And it's because these organizations not only have gone to great lengths to prevent an error, but they also have created the capacity to recover from the error. And I think that's one of the things that really changes a normal organization to a high reliability organization. The ability to prevent and recover. They go hand in hand. So high reliability organizations, by definition, have a preoccupation of failure. They don't dwell on their successes. They dwell on their failures. You have to be obsessive in seeking improvements, and you have to be willing to take risks to try to improve. So these little projects that you can say, let's try it out with this small group of patients on this ward, see how it goes, and then, wow, it worked. Let's do it elsewhere. Or if it fails miserably, okay, we learned from that one. Let's do something different. There's a need to measure, and I'll come back to this. If you can't measure it, you can't fix it. I'll repeat that. If you can't measure it, you can't fix it. Counting is very, very important to doing rapid response systems in any quality effort in order for it to work. The high reliability organization will both prevent and recover. And also there's an emphasis on teamwork as opposed to silos. I think in healthcare, perhaps more than most fields, there's a delineation between nurses and respiratory therapists and physicians, and even amongst physicians, where we work in our own little environment. And in order to take good care of patients, we need to reorganize around the patient in a way that requires teamwork as opposed to silo care. When we first started, at that very first meeting, we were talking about the team, the response team. And it wasn't until we spent 2 days arguing over what's the best team and how do you support the team that we realized that it was a system. And the system had 4 components. I'm not going to go into it there. The point I wanted to make is there's a system of care that required a process redesign. So we didn't invent any new people to respond to these critical deteriorations. We just employed the same people in a novel way to be more efficient and more effective in terms of caring for patients who are suddenly critically ill outside of a place where we wanted them to be critically ill. So in a sense, there are no crises in the ICU because you already have the staff and the equipment there. But if you have the same patient event occurring outside of the ICU or in a hallway or a lobby, that is a crisis. And the crisis is that you don't have the resources there. And the system is going to design both prevention and recovery. John Carnegie and colleagues, he's one of a number of people who have spoken, who have written books on this from the Harvard Business School, created a term called adaptive disruption. And what this is you create a new process or a new device, and it can start out very slowly, but ultimately completely disrupt the way you do business or disrupt cultures. The obvious example is smartphones. Smartphones have put cameras manufacturers out of business. Laptops, I see fewer people in line at the airport carrying laptops. They're using their smartphones and other small devices. Pagers are almost an anachronism. Phone books, when was the last time anybody saw a phone book? Right? Maps, nobody uses maps anymore. There's an organization in the United States, the Automobile Association of America, and they made their livelihood off of telling people how to get from here to there. You don't need that anymore. You just ask your phone, and they tell you, if you're going to walk, if you're going to run, if you want to have the scenic route, it's all there. And this very simple device, which used to be just a telephone, has completely transformed not only the way we do business, but even the way we communicate with each other. Facebook, Instagram, Snapchat, and so on, have created entirely new cultural reorganization. I think rapid response systems are very much in this category. And I dare say most of you here have felt the pushback in your organization from you going in and taking care of suddenly ill patients. And the pushback can come from the nurses on the floor sometimes. It can come from the home team physicians. Even administrators may not like new people coming in to take care of patients critically ill. The system goes beyond the suddenly deteriorating patient, though. At the University of Pittsburgh, we had, I think, 13 different rapid response teams, and have counted more than that now. And there's now many papers in the literature, this weekly now, let alone monthly or annually, papers on the obstetrics rapid response team and how to find lost patients, aggressive individuals, difficult airways, sepsis, second victims, organ donation. We even had rapid response teams for admitting patients and discharging patients, and for turning over beds as we discharge patients. Right? Because if you empty a bed, if you don't turn it over quickly, you can't move those patients out of the ICU. And if you can't move them out of the ICU, you can't move them out of the emergency department. If you can't move them out of the emergency department, the wait time in the ED lobby gets very long and very, very dangerous. So I want you to start, if you haven't already, you need to be thinking of this system not only as a system for caring for deteriorating patients, but as a way of reorganizing care around problems that require rapid fixing in the hospital. I think the future for rapid response systems is going to be one of defining the issues where we need to just improve the way we care for situations, not only patients. The hard part is finding the events quickly. You'll see there'll be a number of sessions during this meeting regarding the best way to monitor patients or to trigger a response, how to fix the afferent limb. There's a number of companies outside who have created really fantastic ways to detect deterioration in patients. Incidentally, I want to emphasize our thanks to those people, not only for supporting this conference, but also supporting the work that we're trying to do in improving healthcare. When I look at the types of devices available now compared to 10 years ago, it is astounding the work that these companies have done, and clearly they are listening to what is happening at these meetings. So you should speak up about things you might like to see, because they will listen and they will make better toys for us to use to take care of patients better. We need to be able to create better triggers to alert the responders or the experts. We need to design the responses and train people to behave according to the design. A word about counting. Counting is really important. It really helped us get the train out of the station at the University of Pittsburgh. Knowing and posting the number of deaths that occurred that were preventable in our hospital was a huge motivating force, even as physicians were telling people that they will fire the doctor or they will fire the nurse that calls the rapid response system out. We used to call it the parade of the cadavers. And counting those preventable deaths is an extremely potent force in helping to improve care. And I've listed a number of things that you can count. Some of them are very direct. Mortality is very direct. But nursing retention is a great measure of nursing satisfaction. I learned this when we were reviewed by an external organization. They wanted to see what this new thing was, and they came and they interviewed people. They interviewed almost 100 nurses, and they found out that in that group, I don't remember the exact numbers because it's quite a while now, about 30 nurses had left our organization, only to return within 6 months because they felt safer at our organization than the one they went to, even though they were paid less at our organization. And that number, the retention rate for nurses and the recovery rate for nurses, was very powerful in helping our organization really get invested in rapid response systems. And you could see some of these others. I threw in bed turnover, because this was a huge dissatisfier in our organization until we created a team, the ADT team, which was responsible for admitting, discharging, and transfer of patients. And it had nurses, physicians, administrators, and housekeeping on it. And the goal was to get, when a bed is empty, it was ready to admit a new patient in under 30 minutes. And so counting how many minutes it was until the bed was ready can be a very useful tool for improving your organization. Sometimes you have to be a little bit creative about what to count, and it's okay. Having surrogates and surrogates for surrogates is okay, as long as you have a number that has some sort of clinical meaning. That is a good thing. I think enhanced monitoring is absolutely inevitable. What do I mean by enhanced monitoring? I'm not talking about the depth of monitoring or the types of things that you can monitor. I'm talking about the breadth of monitoring. For the past 60 years or so, maybe 50, we've used EKG monitoring, which initially was stationary and episodic, to continuous EKG monitoring, and then to mobile or wearable EKG monitoring. This was the best we had for quite some time, but now it's changed, and I think there's an interesting driver that is going to change how hospitals approach monitoring. But part of it, for sure, is the types of devices that are available for monitoring. But I think it's actually going to be a different thing that's going to be changing the monitoring system. So just a show of hands, who here has at home or is wearing some sort of physiological monitoring for step counting or heart rate monitoring or calories? Just raise your hands high. So this is pretty good. Now, you're a pretty smart group of people, but I bet about 1 in 5 of you is wearing a monitor right now. Okay? That's about the same rate as people who are admitted to the hospital. How would you feel about monitoring yourself before you get to the hospital and not monitoring yourself continuously when you're in hospital? Show of hands. Who likes that idea? All right. So I think it's crazy to think that we're not going there, literally crazy. This report just came out earlier this year where a patient came in with atrial fibrillation. They didn't know whether to cardiovert or anticoagulate, leave the person on anticoagulation for a period of time. He was wearing a smartwatch. They interrogated the smartwatch, found out that he had gone into atrial fibrillation just hours before. They cardioverted him and discharged him home. This is the tip of the iceberg. And I think that the driving force is going to move away from administrators and towards patients who are going to demand not to be taken off of monitoring devices that they're wearing all the time. And I think we've actually reached the tipping point when 1 in 5 people in this room is wearing a monitor continuously. And you go into hospital, it's only going to fuel the demand. So expect that, plan for it, promote that, because it's happening. So there's a lot of things we don't know yet about the rapid response system. We certainly don't know who are the best responders. There's evidence that nurses are great, EMTs are great, even respiratory therapists are great, physicians are great. But which team for which situation, does it matter? What is the resource cost for these things? We haven't sorted out what's best, nor have we sorted out exactly which type of monitoring is the best for finding whatever it is you want to find. Deteriorating patient, I think it's going to be some sort of continuous physiological monitor, but things like tracking nursing coverage in wards and bed turnover rate and cardiac arrest prevention, we haven't sorted out these things yet. We don't know how good rapid response systems can be. At the University of Pittsburgh, now others have done this. I'm just speaking from my own personal experience. We started out with 365 cardiac arrests per year at the hospital. When I left there after working on this for about 7 or 8 years, we had 114 cardiac arrests per year. So that's like 250 saved lives annually. It's astounding how it can how effective a good rapid response system can be. And I don't think we know yet whether we can achieve zero, but I think people are starting to understand that that's a doable number, and we really have to be focused on that. Every death in hospital that isn't supported carefully through caring for patients who are NFR or preventing a critical response is going to be very important. We don't know the epidemiology of deterioration yet. We're working on it. We're looking at the different types of monitor, different types of patients, location in hospital, types of medicines, but we really haven't sorted it quite yet. And we don't know the epidemiology of events, rather than some very broad brush things like whether there's a monitor or not, time of day, day of week, and so on. So my predictions are hospitals will become high reliability organizations. For the airline industry, this is a trek that took almost 100 years. And it's still going on. I think we'll do faster and better because we have them to learn from. But any organization that doesn't become an HRO is destined to close. I think it is very near to the time that all patients in hospital will have continuous physiological monitoring. At our second consensus conference, we thought that maybe by 2020 it might happen. I think we're dead on for that amongst first world countries. I think Fitbit type of technology is going to rapidly move from the fitness to the healthcare environment. I think EKG monitoring, which is certainly a good thing, is going to decrease in importance because of its cost, mostly. There are some lower cost alternatives becoming available. Physiological monitoring is going to be more important. Our task here is going to be to grow the breadth and depth and quality of rapid response systems. We have to think of the system as the system for the hospital care and not just around a particular patient who may be deteriorating. We need to work on research, education, We need to be promoting the adaptive disruption of rapid response system because we are talking about reorganization of all of healthcare, not just the deteriorating patient. And we need to be working hard to change the culture of healthcare away from silos and towards teams. I want to reiterate that we are having a meeting next year. Everybody here is cordially invited to attend. Chicago is a lovely city if you haven't been there. And we hope you're there for our 4th annual society meeting and our 13th annual conference on rapid response systems. Thank you very much.